So we're going to get started. So those of you who have joined us, I want to welcome you to the 36th Yale Career Panel on a candid view of the medical profession. And I want to just take a moment to make two comments. One is, obviously, we're all in the middle of a very, very challenging coronavirus crisis right now. And I can't say how appropriate it is for us to be featuring the medical profession and doctors at this time, because clearly they are in the front lines and they're the ones who are key to keeping us healthy if we get sick. And so I want to have a thank you to all of them. And in fact, it was challenging for them, particularly Dr. Lee, who is currently at the hospital, and she's a resident there. So she's actually taking care of, and she and her colleagues are taking care of 190 people who are infected. So my gratitude to all of you, and particularly those who are serving in the ER, et cetera. So I just want to say, though, a couple of things. One is we were going to have this part in person and part by video conference, but I think it was an easy decision to switch entirely to a webcast for the obvious health reasons. The other is this program was started in 2012. When a group of us who are Yale alumni came to the conclusion that there was really no resource for Yale students and Yale graduates to get sort of candid, unbiased information about different professions. I think we were particularly concerned about the ones where there were a lot of TV shows, and I guess the medical profession is one. I mean, there's so many shows about doctors and emergency rooms, so forth, and a lot of them are rather glamorous, when we know, in fact, a great deal of the profession is important, but not necessarily as glamorous. So we decided to start this series, which now we did not intend for it to go as long as it has, but this is now we're in the 8th year, and this is the 36th Yale Career Panel, and we've also done 5 Yale Career fireside chats that are not on professions, but more on issues such as how to get on boards, how do you network, how do you make major career changes. So it's more career issues as opposed to professions. I'm actually very pleased to have this particular group of doctors who are on, and we try to get some diversity by type of medical profession, gender, age, etc. It's not perfect, but we try our best. The last thing I want to say before we start is that the one thing this panel will not do is it will not help you understand yourself. And I strongly encourage all of you that if you haven't already done so, really find a way to get a really candid and thoughtful understanding of yourself, what your needs are, your attention span. Can you work on things that take 5 years to finish? How important is money to you? Can you live in a city? Can you live in the country? These are all critical things that even if you get very good information about a profession such as a medical profession, if you don't understand yourself, the likelihood that there's a good match between you personally and that profession is still rather dubious. So I strongly encourage, and there are a lot of ways to do it, including speaking with friends who are willing to be honest about you but know you well, et cetera. So those are things that I would encourage you to do. So before we start, though, I would say that we have about an hour. What we're going to do is we're going to go through the questions, the 6 questions that were on the invitation, such as, where's the profession heading, good and bad, et cetera. And the panel will address these questions as we go through them. And the plan is to make sure that we leave at least 10 minutes or more at the end for questions from the audience. And there are two ways that you can ask questions. If you look at your screen, there's a chat function, and I think everyone knows how to use a chat function. And you just type in the question and we'll see it and we'll be able to choose questions to answer. The other is there is a Q&A function, which is actually very similar to the chat function, where you can type in your questions. And in fact, you can type in your questions anytime you want. You can do it as we're going through the panels, set questions, and we'll just take them up when we get to the Q&A section. So first, just the introduction. I won't read all of the bios because I know all of you are capable of reading the English language and got the invitation. But to your left at top is Dr. Alan Astro. He is the chief of the Division of Hematology and Medical Oncology at the New York Presbyterian Brooklyn Methodist Hospital. He is a Yale undergraduate and a Yale Medical School. On your counterclockwise at the bottom, we have Linda Lee. She's a resident at the New York Presbyterian Brooklyn Methodist Hospital and went to Yale Medical School. And I'll let you guess which of the two panelists actually know each other from what I just said, right? And the third is a long-term friend of mine, Dr. Dolgen, who is a professor in surgery and pediatric at the Zucker School of Medicine at Hofstra Northwell, and he is a Yale undergraduate. So everybody, one way or the other, has an affiliation with Yale, and Dr. Dolgen spent most of his career as a pediatric surgeon. So with that, why don't we start with the questions? You know, I think certainly Alan, Dr. Astro and Dr. Dolgen, when you first went into medical school, et cetera, but the world was quite different, right? And in fact, what it was like to be a doctor was quite different. Maybe if you could start out by just saying, what's changed since you first went to medical school? How has the role or the profession or life of a doctor changed? And then we'll all put on our crystal ball and we'll ask Linda as well, sort of where do you think it's heading, you know, and both good and bad, right? But things are changing.
Steve, why don't you go first?
First of all, Peter, did you see the chat comment that people can't see anybody but you yourself? I don't
understand because I can see everyone. So why don't we ask if any of the other people cannot see the other panelists? Because I can see all four.
So I think in the top right corner, there's speaker view.
Yeah, no, yeah. The person who is it's their mistake. Everyone can see all four.
Okay, good.
If you go to the top, there is a thing that says speaker only, whatever. So it's one person who's got the wrong setting. So
well, if you regard that as a mistake, Peter, and any kind of technologic misstep as a mistake, then my life is riddled with error and embarrassment. So you got to rephrase that.
Well, having known you for many years, I would endorse your statement. But so let's start.
How has medicine
Alan,
changed?
You can start, Alan. Maybe you can start with your perspective over time, because it's
sure.
Good to look at history because
sure.
It feels you touchy teaches.
Okay, so I graduated from medical school in 1980. So a number of things. One of the most dramatic and obvious changes in the medical profession is that when I graduated from Yale Medical School, I think it was only about 10 or 15% of the students in my class were women. So there's been a huge change in the profession in that regard. Now, slightly over half of all new doctors are women. And I think that's only to the benefit of the profession, that there's a much more even balance of men and women as doctors. It gives a different perspective to medical care, and it gives people more choices of what types of doctors they can see. When I graduated from medical school, far more doctors than now were entering the private practice of medicine. More doctors now are taking some type of employed status in some larger organization, whether for a hospital or an HMO. Now, it's a very big country, so my experience is in the New York area, but I think that's true generally. There are doctors still in private practices, but fewer of them. A third change has been there are a lot more options of what people do in medicine. When I graduated from medical school, most of the students in my class did internal medicine residencies. Now, the students are much more aware that there are many other things that doctors do. So, for example, in radiology, when I was a student, there was no such field as interventional radiology. Now there's a whole new field, and there are many new fields in medicine that have opened up that we can talk about. And I'd say one other thing that's a big change. When I graduated from medical school in 1980, AIDS was not known as an illness. And it ended up that I spent a good part of the next 20 years of my professional career taking care of patients who had an illness that I had not even heard of, that did not exist when I went to medical school. So as we can see now, medicine is very highly influenced by the changes in the larger culture, the changes in public health, the changes in economic organization, and we all have to be prepared for those sorts of changes.
Yeah. Dr. Dolgen, same question. How's it changed since the time you first came out of medical school?
I confirm everything I just heard. I took notes. I had the opportunity to think about it for a minute. I'd say the emphasis on evidence, data, like you hear Dr. Fauci talking about every day, that is a good leveler because young people have access to information sometimes more readily than the old stodgy folks. And the idea that the mentor is the sage who can just dictate what to do and everybody follows, that's not tenable. There's an increasing need for teamwork, especially in hospital-based medicine. And there's a striking growth of technology. The role of technology is omnipresent. The electronic medical record has a well-deserved bad reputation in many ways. It's going to be better and vastly better in 10 and 20 years. The imaging is an extraordinary advance, and it affects teamwork too. Interventional radiology gets activated when some other clinician activates it. In the field of oncology, if you have the worst skin malignancy, a melanoma, the one skin malignancy that so famously metastasizes and can be catastrophic when it's deep, we used to have to guess as surgeons what lymph nodes was that spreading to if we wanted to possibly help stage, possibly help cure a patient by dissecting the lymph nodes. If the melanoma was in the middle of someone's back, it could be one of 4 places. Now, a technician can help inject with an agent drain to the lymph nodes, and you can biopsy the lymph node where that radionuclide resides, a so-called sentinel node. And then, of course, in surgery, minimally invasive surgery is expanding enormously. You can take out a brain tumor through a little tiny fine fiber optic instrument through a nasal passage. You don't have to open the skull and all the morbidity of a so-called craniotomy. And finally, Peter, the sense that I had when I went to medical school, that it was a good field for lifelong learners, that has proved true.
Yes.
So when we just heard about a disease that didn't exist when you finished medical school, we've all come to realize we have to be agile and learning more and more every day. And the old adage that there's more you don't know than you do know is proved true day in and day out.
So Linda, let's turn to you because you're starting your medical career from your perspective, but also what you learned from people around you and your colleagues. Let's take the crystal ball and what do you think what are the changes that you think are going to happen, good or bad, right, over the next 10 or 15 years? Because obviously, if you go to medical school, you got to think 15 years ahead, because that's where your career is going to be, right?
Right. So I definitely agree with everything Dr. Astro and Dr. Jojen said. I think just kind of coming out of medical school and, you know, entering my first year of clinical medicine, the role of the physician certainly is a little different to how, you know, what I've portrayed going into medicine. The kind of envision I had going in is you're sitting there talking to the patient for, you know, learning everything about them and learning about their entire life. And having the time dedicated to do that is not necessarily true, in that right now, you know, when you're in clinic, you have a very finite amount of time. And while doing so, you have to incorporate note taking, or, you know, writing in charts, making sure everything's done, and incorporating a lot of technology to make sure that documentation is done. So to an extent, I think in the future, you know, we have to be a lot more flexible in how we manage the patient encounter. And I think the field is changing in that way, that there's a lot more structure and influence of technology and documentation into our general day-to-day patient interaction.
Now, playing a little bit of a devil's advocate, let me play back some of the things I hear from, you know, doctors, you know, that I know. You know, on one hand, a lot of people, they're very excited about the new technologies and new information and so forth, as Dr. Dolgen said. On the other hand, a lot of people are saying, as Dr. Astro said, it's not like they're all saying it's very exciting to work for a hospital or a corporation. It's that they're being forced to, because it's become so challenging because of paperwork and so forth and liability to be an independent practitioner. So, you know, so their attitude is more, it's not because everyone loves to work for a company or corporation, it's that increasingly you don't have much of a choice. And so that's one aspect I'd like people to comment on. I also think that people have said, and I guess Linda, you've alluded to a little bit, which is, you know, there's so much pressure on the volume of patients that you have to see that, you know, at times it just makes it really challenging, both physically, but also in terms of your sense that you have enough time to, you know, to take with each patient. And it's the same thing, it's the same economic pressure, right, in both cases. Any comments about that? And, you know, maybe we can start with you, Linda, and then anyone else.
So as a resident, I don't have as much economic pressure, I guess, but certainly from a time pressure perspective, we have to see an X number of patients in clinic and make sure everything's taken care of. So that's certainly there. I think partly we're also more accountable for documentation as well, which, you know, again, you have to make sure you're documenting accurately. And so throughout the encounter, you know, you don't want to be missing things. But again, I have a very limited clinical experience, so I think I'll defer that to Dr. Astro and Dr. Jojen.
Dr. Astro, your comment on those 2 points?
So I think that physicians have certainly lost a lot of our autonomy in, you know, the, how many years now, 40 years since I graduated from medical school. There's a lot more oversight of what doctors do. And even the electronic medical record, where we have to put everything down, as Dr. Lee has mentioned here, the documentation, the record, it's all overseen by others. And so that creates a lot more stress, I think, for doctors. And there's a lot, as Steve mentioned, that, you know, there's much more technology in medicine. And so it's very helpful to be part of a large organization that can support the technology you need. As it turns out right now, because of the COVID epidemic, I'm having to see most of my patients via telehealth. Now, it turned out that the institution I'm associated with, New York Presbyterian, had invested very heavily in telehealth so that we're able to see our patients through this technological system. But more and more doctors are finding that because we rely on technology, and that is very capital intensive, we have to be part of a large system. And that has its good parts and its parts that can be very frustrating. Linda, we've lost you.
Oh, she's coming back.
Yeah.
There we go.
So we have to work with administrators. Steve, you could comment. You know, the administrators want to be helpful. They have many pressures that they're under. Certainly right now, they're all under tremendous pressure to organize the care in such a way that we can take care of the large number of people who are presenting to us with a brand new illness. But sometimes I'd say we as doctors may feel that the administrators don't fully understand our experience. Steve, I don't know if you want to comment on that.
Linda, my name is Steve. I want to tell you something about feeling overworked and stressed and all that. You'll have a lot of choices when you finish your residency, and if you can tell what stresses you and what you want to avoid, you can put yourself in the right kind of position to limit those kind of stresses. And when you finish your training, you'll get the biggest promotion of your life, because you'll increase your income by 3, 4, 5-fold, and you'll decrease your workload by a similar amount. You will not get promotions like that very often in the future, so don't expect it to be exponential. When I was a medical student a few years earlier than UL, we used to joke about hospital administrators. They used to say, you know, my door's always open, but I'm never there. Those days are done. If you want to be a specialist of any kind in medicine, you are totally dependent on hospital administrators. And if you have good ones, it's greatly to your advantage. The resources are absolutely critical. And Peter, it's become a team sport. You're putting a negative twist on this, Peter, that, you know, as what you call the devil's advocate, that you aren't autonomous. If you're really looking for a field of pure autonomy in medicine, it's a little tricky today, and you might have to go somewhere rural and try to be a family doctor. But if you want to have a hospital-based practice, or even be on the front lines as a general doctor, you have to have very, very good teamwork where you can get resources quickly. And within the framework,
I'm only being a devil's advocate to make sure we have a balance, right? And that's the purpose of this, which is to see both sides of the coin. You decide to use it.
Well, it's not if it's a coin, it also has an edge, for heaven's sake. I think that you know, certain people should stay out of medicine.
What type of people? What type of people?
The benefits.
Okay, this is good now. Now this is going to be the devil's advocate. Who should stay out of medicine?
Well, anybody on the other side of that coin you're describing.
Well, wait a minute. There's no profession that is perfect, and there's no profession that I know of, and we've done 37 of these things, that doesn't have pluses and minuses, period. Well, and the medical profession is no different from the good things and bad things about it being a lawyer or about being a consultant. So I think the key here is to make sure that the audience has the information they need so they can make the right decision for themselves.
Medicine is a terrible profession, Peter. It's horrible. If you're looking for a small job that doesn't take up a lot of volume in your life, if you're looking for a living that will allow you to do the things you really love, a very bad idea to go into it. You'll be disappointed and you won't serve your patients well, and a bad mistake. If you're looking for a small profession and if your main goal is to make money, it's a terrible mistake.
Yeah. Yes. I would agree. If your main goal is to make money, it's a mistake. Yes.
Let's go into the next question, which is, you know, and actually this is an offshoot of what Dr. Dolgen said, which is a lot of this is fit. So all of you have been working, in the case of Linda, it's a shorter period of time, but in the case of Dr. Dolgen and Dr. Astro, it's longer. Any generalizations about what kind of people tend to end up doing well and are happy as doctors, but other people for whom, whether they leave or not, you know, end up either a bad fit or personally or just skills, right? Dr. Astro?
Yeah. So actually, there's been a big problem. It's well reported in the medical literature of so-called doctor burnout. You know, where doctors become cynical and they don't care. And the question is, what type of people are at risk for burnout? Now, there's aspects to the work that can make you burn out if you feel you're overworked and underappreciated. But I think it's partly also internal to the doctor. I think, Steve, you hit it on the head. You have to go into medicine, it's helpful to be what's called mission driven. That means you're going into it because you're not, you know, everyone likes to get paid, but that's not the main reason you're going into the field. You're going into the field because you want to be working as part of a field where you're working with others to take care of people who are sick, help people in need, and improve the public health. And so when there's some kind of public health disaster, as we're in the midst of now, then you don't shy away from putting yourself at risk to some degree. As Dr. Lee is now on the absolute front line, she is taking care of a large number of patients with the COVID infection in our hospital. She has a young child at home, and yet, Linda, I don't see that you have any, you may be worried about it, but do you feel that you regret that you're doing this?
No, absolutely not. I think this is an exciting time to be in medicine, actually, you know, with just touch a little bit on this coronavirus. You know, we know very little about what's going on, so we're constantly learning. And, you know, again, going back to what everyone has been saying, you're a lifelong learner, and this is a fantastic opportunity to learn, read literature, and practice on the little knowledge that we have on coronavirus. At the same time, it's been very enjoyable for me to see the difference of someone coming in the ED having so much, you know, difficulty breathing, and seeing them walk out without any oxygen requirement. So I think you have to go into medicine knowing why you want to go into medicine, wanting to take care of people. Sure, I am worried that I may bring this back to, you know, back home, but at the same time, there's so much value in my role in the hospital that, you know, and this is exactly why I went into medicine, right?
Linda, the next question is about career paths. And actually, I think it's interesting to start with you and say, what do you see as the sort of the path from where you are going forward, like the next 10 years? Just give the audience a feel for what you're going to be doing and what that path is going to look like.
So I'm actually going into radiology, which is completely different to what I'm doing right now. As part of the radiology requirements, you have to do a year of internal medicine where you learn about general medicine.
Yeah, we'd love to keep you in medicine, Linda. You're doing a great job as a medical resident.
Thank you. I am having a lot of fun in internal medicine, but radiology is, you know, completely different. You're doing a lot more imaging. Dr. Astro mentioned interventional radiology, where there are more also procedural involvement in radiology as well. So, you know, I'm excited for the incorporation of technology. I'm excited to be doing a lot of procedures, but at the same time, incorporating the internal medicine skills that I've learned, the clinical medicine that I've learned in internal medicine.
So what will happen? So tell us, if you go the radiology route, what happens over like maybe the next 10 years?
In terms of the field?
No, your career path, you know, where you're going to be working, what you have to do, et cetera.
So the next 4 years, I'm going to do radiology residency at Jacobi Albert Einstein in the Bronx. And then after that, I'll probably do a fellowship in interventional radiology and then practice in a hospital setting, most likely in interventional radiology.
Okay.
Yeah.
And so you'll be working for a hospital, right? In their department, radiology department, basically, right?
Yeah, so interventional radiology, or just diagnostic, interventional radiology, for the most part, you practice within a hospital system, just because, you know, you need the referral base from all the other folks in the hospital. So
Yeah.
hopefully that's what I'll be practicing.
Yeah.
It gives you an opportunity also to do a lot of research as well.
Yeah,
By the way, it's worth.
Peter,
Go
there
ahead,
are
Dr. Estro.
there are private radiology groups, but if you want to do interventional radiology, as Linda says, generally you work for a hospital.
Well,
But
it's
also,
not
I think
just
radiology is a great example of where technology is going to change your world, right, over time, right?
it's not just the patient referrals, of course, it's a tremendous number of resources.
Yeah.
The interventional radiologist is often taking care of the sickest patients in the hospital.
Yes.
It's not the kind of thing you would do in a small office in the community.
Yes.
So I just heard Alan use the word purposeful. I heard Linda use the word
Mission, yeah,
value.
right.
And, to me, Peter, this is what keeps you going as a physician. This is a time right now when it's very easy to talk about a medical career because what everybody is expressing the value of healthcare, and this is what gives you a psychic remuneration. If your eye is on that ball and you get a sense of value by helping people, using your brain to figure out how to do that, and constantly refining your ability, and with luck or God's intervention, seeing patients get better. When Linda talks about that patient who's struggling to breathe and goes home breathing room air comfortably, that's as good an example as any of the kind of rewards inherent in the field.
Well,
Yes,
the one
yeah.
thing that is true is I don't think if you talk about mythology, that is one area that the mythology is accurate. In other words, every TV show, every movie about the medical profession talks about that. They never say, oh, the evil job is being a doctor. They focused on the mission and the personal, ability to contribute and save lives and so forth. So if I were to list the myths about the medical profession, right, that are damaging, I wouldn't say that the myths that are created, and they're not even myths in a sense, in TV shows and movies about the medical profession, they don't miss that point, right? They don't miss the point that there are great things about being a doctor to help people, right? Where they miss are things like lifestyle, or do you really make a lot of money, or other kinds of things, right? But that's a good thing because at least these kinds of things and reinforce one of the good reasons to be a doctor, right? But not everyone goes off to be a doctor. I know a lot of people, my firm, we serve life sciences and chemicals, so includes pharmaceuticals, biotech. And so one of the questions is, do people do other things other than be a doctor? And although all of you are doctors or intend to continue as doctors, I'm sure you know a lot of people who went to medical school, practiced, maybe went off to do research for drugs, right? Or work
for the pharmaceutical industry. I know quite a few people have done that.
Can you comment on some of the other alternative careers that one could pursue somewhere along the line, right? You may be a doctor for a while and then try, but are some of the other career paths that are not uncommon, right, amongst people who go to medical school and practice as a doctor?
Listen, Peter, medicine can't compete with law when it comes to getting the training and then doing something else. Most people go to medical school, become doctors. There's a robust interest in being a physician scientist, and that is variable how it's defined. A minority of physician scientists are self-funded and spending 50 or 70 or higher percent of their time in a laboratory doing basic research, but there's an awful lot of important clinical research. It's so evident now because despite Donald Trump thinking we're learning a lot right now about dealing with a viral pandemic, these lessons were learned by scientifically oriented doctors who were very much preaching in 1918. So.
Oh yeah, absolutely. I'll give you an example just from my own experience as someone I know of different careers you could have that are very positive. So we do life sciences, and one of the senior people in my firm is Dr. Steven Spielberg, who, by the way, did not direct ET, by the way, although he's related to that Steven Spielberg. But he started his career as a doctor, and he was actually a pediatric, he was a pediatric, not surgery. And then he went on and he, became a hospital administration.
Yes.
He then became the dean of the Dartmouth Medical School.
Yes.
And then after 10 years, he became head of all pediatric drug research at Johnson & Johnson. And then after that, he became the deputy commissioner of the FDA in charge of all drugs and devices. So 80% of the FDA. But he is a great example of the kinds of different careers you can have that relate to medicine and making people well and so forth, right? That one could have. And yeah, maybe there are more things you could do if you have a law degree, but I think there are lots of things you can do that help patients in healthcare, with a medical degree, right?
Yeah, I agree with that. As I said, I've had a number of colleagues have gone to work with the pharmaceutical industry, a number of people involved with public health work. So people who work for the City Department of Health who are working night and day now on the COVID epidemic. So there are people, public-spirited individuals who go into the public health realm.
Dr. Fauci, right? For example.
Right, exactly.
Star,
there, are
right?
people, there are plenty of people do that. I have tremendous admiration for people who are now working in public health, physicians who've trained in public health as well. People, yes, as you mentioned, they go into administration of various sorts. Some people are more interested in the business end. Right now, because there's financial issues are very important in medicine. You do need people who are involved with hospital administration, who can do budgets and things of that sort, who also know how to practice medicine and understand the medical issues. Yeah. So yes, I think you are right. While most people who go to medical school end up practicing medicine, there are other opportunities to do other sorts of work that are related to medicine.
But within the doctor profession, there's just a tremendous number of different alternative careers, right? I mean, look at the three of you. Each
Yes.
of you is really quite different. So maybe if each of you could take a minute and just say, how did you end up deciding, how did you end up deciding going to oncology? How did you decide to go into surgery? How did you decide to go into radiology? I think it would be helpful to the audience to understand the kinds of choices you have and how each of you sort of decided what branch of medicine you want to be in. So maybe, Linda, you want to start out? Because, we'll do it clockwise, right?
Yeah.
Okay, sure. So I actually, out of college, I spent a few years doing healthcare consulting and spending some time in the business and the pharmaceutical industry prior to entering medical school. I decided that I wanted to do more clinical medicine, which is kind of ironic now that I'm going to radiology, but I wanted to kind of talk to patients more on a one-to-one basis and have more story-driven approach rather than kind of at the higher population-based level of work that I was doing in healthcare consulting and pharmaceuticals. How did I decide into radiology? So in medical school and kind of throughout my life, I'd always been very good and very detail oriented. I felt that through radiology, you're able to make a lot of interesting diagnoses just by looking at a scan. So I kind of went off with what I was good at as well as what I was interested in. But at the same time, the field of radiology is so evolving with interventional radiology and the incorporation of technology and having the field itself also having a little bit more flexibility in terms of lifestyle and the hours you work, and ended up deciding that was the field for me.
Yeah, just warn you, Linda, interventional radiologists definitely get called in the middle of the night. Just be aware of that.
That's true.
We need you on the weekends.
So Dr. Dolgen, how did you end up in surgery, deciding to go into surgery and pediatric surgery?
I went to medicine because I was a depressed, insecure graduate of Yale College, having majored in philosophy and studied existentialism in the late 60s, early 70s. And I wasn't sure if life had any meaning. And I cured lifelong cure of my depression and anxiety, because I decided that if I could master something that would take a lot of work and energy, that would help the suffering, that would have meaning, and that if that didn't have meaning, nothing would.
No, no. Well,
I went into,
I'm talking about
I went into
surgery and
I
pediatric
went
surgery.
into surgery.
Yeah.
Because like most people who go into general surgery, which is about 5% of medical students, I fell in love with it during my third year clinical rotation. For some reasons too embarrassing to share, for some reasons that I don't know about, and for some reasons that are obvious, like it's verifiable and you can see the results quickly, and hugely gratifying that sense. I went into pediatric surgery because my father was a beloved pediatrician. I saw the kind of joy it brought to him and to people around him. He was a hero in my community.
Yeah. Dr. Astro?
Okay, so when I grew up, I'm a baby boomer, born in 1954. So when I grew up in the New York City suburbs on Long Island in the 1960s, in a Jewish neighborhood, there was nothing a young Jewish boy could do that was better than becoming a doctor. That was the highest thing that you could possibly do. And when I was in high school, I had to do a book report on 3 books, and my dad recommended that I read 3 books which no one would have heard of today, I suspect. Arrowsmith by Sinclair Lewis, Of Human Bondage by Somerset Maugham, and The Citadel by A.J. Cronin. Those were Depression era books because my dad was a Depression era. He was growing up in a Depression era, and what they all had in common is they were about a doctor. So my dad very much wanted me to be a doctor. And I had a very old-fashioned notion of being a doctor, which was a doctor was someone who took care of individual patients. I didn't know a whole lot about radiology and anesthesiology, and I wasn't that interested in surgery myself. That wasn't my main focus. So when I went to medical school, I thought the only type of doctor was really like an internal medicine type of doctor. And most of the students in my class at that time did go into internal medicine. The best students went into internal medicine. They didn't know a whole lot about radiology and dermatology and anesthesiology at that time. So, and then when I did my medicine residency, I very much admired my attendings who were in oncology and in hematology, and that's how I ended up going into this field. And I have no regrets.
It's certainly become a very important but also sexy area, right?
Yes, well,
where so much research is being done, right?
Yeah, there have been enormous advances in our understanding of cancer. I would just want people to understand that while there are miraculous advances in medicine, and Linda has the gratification of taking care of so many people who are coming in severely ill with COVID and seeing them walk out well, and because of the excellent work she and her nursing colleagues and the whole staff in the hospital are doing. There are a lot of illnesses where people get sick and they don't recover from, or they have their chronic illnesses, and you have to help people through whatever chronic illnesses they have, and you have to support them through those tough problems. And so that's part of being a doctor too. You have to have a lot of patience being a doctor. You have to be willing to understand that there's humankind is we're a very varied species, and you have all kinds of people you're dealing with from all walks of life. And I think you have to have a certain type of compassion for other people and love of humankind to really be in this field. And one other thing I'll mention is, as Linda has noted, she's gone to college, she's gone to medical school, she had several years in another job, but she still has quite a long haul ahead of her before she can practice independently. So if you want to go into medicine, you have to be prepared to put a long time, a lot of years into it. I mean, I felt I gave away, I wouldn't say gave away, I devoted my 20s to learning how to be a doctor. So it's a long haul, so you really have to be dedicated to it and really want to do it. There are other, you know, you can become other things you can do with health that don't require to put so much time into it. You know, I have a lot of admiration for nurse practitioners, for example. They do great work and they accomplish a lot, and they have a lot of independence, but they don't have to go through quite as long an educational training period as you do in medicine.
Yeah, in fact, I'll tell a short story, and Dr. Dolgen will enjoy this because it relates to a panel he was on. We received an email about a year and a half ago from a Yale graduate who said, you don't remember me, but I went to one of the Yale career panels on the medical profession. And Dr. Dolgen, it's one of the ones you were a panelist. And he said, I was an English major, and I had gone out, and I was at the time was working in journalism, and I attended the Yale career panel on the medical profession, and I listened to what all the doctors said and so forth, and realized that that was the right thing for me. And then he said, but I had to go back because I didn't have all the science courses, so I had to go back to Yale. I had to take the science courses that I didn't have. And he said, I want to tell you that today I'm a second-year medical student at UPenn Medical School, and I'm very happy, and I'm absolutely 100% certain this, pluses and minuses, that this is the right place for me.
Right.
And that is why we do these things, but it is also a statement of, it's a bigger statement, which is he clearly thought about all the issues, right? And he thought about himself and what was a good fit for him. So
Peter, listen, according to my computer, it's 5:16, and I see 10 questions on your chat box. I'm so interested to know.
I have the same question. I have the same screen on YouTube, but the first 7 are, do you see only one person or 4? So in fact, there are 3 questions. And in my prerogative as moderator, I was going to wait a couple more minutes until we had enough to cover like 10 minutes. But at the insistence of Dr. Dolgen, I will move to the 3 questions that are on the screen here. So the first question is from Will Robinson, who says, how would proposals like Medicare for All impact your work and career? And this can be, I throw it open to any panelist.
Well, I would say it may lead to reduction in income of many doctors, but it will also lead to less hassle and frustration in dealing with the whole, you know, range of different insurance companies and worrying about whether people are covered for whatever you want to do. So personally, I would say that it's a complicated thing having Medicare for the whole population, but in principle, I favor it. I would say that. I don't know, Steve, how you feel about it.
I think over the last 100 years, America has developed as good a set of academic medical centers as any place in the world. Was not at all true in the 19th century. It has been since the early 20th century, increasingly so. Where we are behind is in an equitable distribution of health care.
Yes.
Absolutely necessary. And rather than something to be feared, it's something to be embraced.
Yes.
Linda, any comments? Impact of Medicare for All?
So I grew up in New Zealand, and we have a very socialistic medical system. I certainly agreed that doctors will not get reimbursed as much should we have Medicare for All, but at the same time, I think there will be much improvement in primary care. You'll see more preventative medicine than the specialized system that you see in this country. As well, I think at the basic level, healthcare will improve for every American should there be Medicare for All. But at the same time, I think there's a lot of issues in how do you go about implementing it given the current state of the healthcare system here.
Peter, I invoked my dad a little while ago, and I was remembering something because it's really hard to predict the future. But I will tell you something. In the 1960s, when Medicare and Medicaid got established, the physicians in my dad's rather atavistic medical community thought that this was communism, socialism, and doctors would all be on bread lines. And my dad had the savvy to say to me, son, doctors will never be on bread lines, And how many cars can you really drive at any one time? You know, at any one time. And the idea that the doctor won't be able to put her children through college or live in a comfortable home is really, really unlikely. And again, if your goal is to make a vast amount of money, that's absolutely fine. And get your feeling of value by supporting doctors. But don't go into medicine if you're dependent on becoming one of the richest people in the neighborhood.
The second out of the 4 questions comes from Sherry, who says, as an undergraduate, I have found a love for teaching. I have met a few physicians who also have the title assistant or associate professor of clinical medicine. What job does this entail, and what is the path to become one? Well, that's a specific question to be answered by anyone on the panel.
Well, I'll start off with that. So if you see someone like, I'm a professor of clinical medicine, what that means is that my title, I'm employed by actually a medical school. I'm employed by Cornell Medical School, and I teach the students and the residents, and I might give an occasional lecture, but it's not like I'm teaching a class or teaching a course. There are people who have the title of professor of medicine, and those people will have more laboratory-based careers where they're getting grants, and a good part of their time they're spending in a laboratory. And then there are others who are more in, they're taking care of patients all the time, and they do some voluntary teaching. So there are 3 different types. I would just say that it's not like teaching in a university for the most part.
Yeah.
Steve,
any others?
Look, I'm an academic. I'm a full professor of medicine and pediatrics. I was that at Mount Sinai. I am that at Hofstra. Every university has its own specific criteria. I am not at all sure I would be a full professor of surgery and pediatrics at Harvard, which I mentioned as you know, one of the most demanding universities as far as promotion, but teaching is absolutely essential. You have to do more than teach. You have to create programs, create a curriculum, write about education, and do a moderate amount of publishing. There's all kinds of publishing one can do that doesn't involve basic molecular biology, and that would be the kind of publishing I've done. And I have taught courses, you know, today in modern didactics, which certainly have affected many medical schools. You don't do quite the same kind of teaching that I have done earlier in my career, which is a series of lectures with some questions and a whole bunch of slides. But there's a teaching day in and day out in medicine. If you love to teach, you will be embraced by your mentors, by your dean, by your chairman, because Linda can tell you, 4th-year students teach 3rd-year students. Interns teach 4th-year students. Junior residents teach interns. What's amazing today is that the interns teach the attendings, because young people have such a facility with gathering information. And again, the idea that because I'm old, gray, and bald, I know more, just flagrantly untrue. I may be able to synthesize it and have a better basis to incorporate it, but the young people may be more aware of what's new and important. So it's a lifelong learning, it's teamwork, and you can get a master's in education and be a physician, and you will be highly marketable in a hospital-based practice.
good.
Third out of 5 questions. Was there ever a time that you doubted your decision to go into medicine? And if so, how did you get through that? That's a good question.
Beautiful question.
Any open to anyone, you know, who is on the panel. Of course, you could also say, you know, I always doubted whether the other panelist should have been a doctor.
Yeah. So I'll take that one on. You know, you could always, we all wonder about things, you know, you did this rather than that, could have done this rather than that. So yeah, absolutely, I've wondered, but I'm very happy that I became a doctor. and I'm very happy with what I do. Now, I would say, I saw someone, there's a question that came up, have you ever thought of leaving clinical medicine?
Oh, that's question number 5.
All right.
Go
so
ahead. Go
question
ahead.
number
You
five.
want to answer
I
it
would
because
say,
they're related to each other.
you know, in any type of work, there are frustrations. And, you know, sure, there are moments of doubt. You know, I have a big administrative role here. And so I think as Steve would be well aware, if you have any kind of administrative role, you work with, you're trying to get resources, trying to get space, you're trying to get permission to hire people. And that's complicated. You know, it can be fairly frustrating at times. But, you know, today I'm feeling, even though we're in the midst of this global disaster, I must say, and my hospital is being hit very hard by it in particular, I would say I don't have any doubts about my decision to become a doctor.
Yeah. Either panelist?
So I think intern year is hard. Intern year is probably the hardest thing I've done so far. There have certainly been days, when you come back home, whether you've had, long days or just difficult patients or difficult families, when you come home and think about why you go into medicine. But this is all part of training. At least that, for me, that's how I've seen it. And at the end of the day, I think you have to think about what the motivation of coming to medicine and going back to what your mission is. And so if you ultimately still want to help people and make a difference, that's what has so far gotten me through intern year thus far.
Right. Yes, Peter, let me just add one other thing here, and I'll then let Steve weigh in. Like, personally, I have a lot of intellectual interests. I always have. I was a history major in college, and, just like to read history and philosophy and trying to find, medicine is, a lot of it is caring for people, and it's not often highly intellectual what you're doing. So if you have a lot of intellectual interests, I've had to find ways to find an outlet for that part of myself. I would just say that you have to be aware of that it's caregiving, a lot of it, and helping people with their problems. It's not always highly intellectual work. And since I have intellectual interests, I've had to find other ways to express that.
By the way, I want to tell a short story that's directly relevant to the comments made earlier, for a personal story. So I started at Yale, and I was a physics and math major. And my parents said there are only 2 professions that we will approve you're going into, either being a doctor or being a professor. And by the way, they didn't care what kind of professor, any professor. So I was a physics and math major, and between my sophomore and junior years, I had an internship at the Mayo Clinic, and I was assigned to 2 doctors, and I just followed them around for an entire summer. And the most important ending of the story was at the end of the summer, they said, "Can we have lunch with you? We want to give you our impression of you and your interests." I said, "That's great." So they sat down and they said, "We have good news and bad news." I said, "Okay." So the good news is you would be a very good doctor. You're science oriented, you like solving problems, you like being with people, you can relate to them and so forth. The bad news is you shouldn't be a doctor. And I said, "You've got to be kidding." And they said, "The reason is that we've gotten to know you. And some of the issues that, Dr. Astro, you mentioned," he said, "it's going to take a lot longer than you personally, I think, will tolerate in order to become a doctor." And then they went through the 2 or 3 things, and lifestyle issues, right? Your ability to control. And, they were absolutely right. Now, they totally messed up my life, because then I had to switch from physics and math to economics and figure out how to, change my degree. But those 2 doctors really helped me understand myself, but more importantly, why I should or shouldn't be a doctor. And it was very interesting. So it's directly relevant to what we're, all talking about, right? The last question here, and then we're going to end, is how do you feel that the changing step 1 to pass-fail, I don't know what step 1 to pass-fail is,
No, yeah,
will change the landscape of applying to competitive residences? This is a very specific question. So anyone who wishes to answer this, please do so.
Yeah, that's a hot topic now. I really haven't followed it too closely, though. Linda, you'd probably be familiar with that.
Yeah, so normally prior to, I guess, next year, residencies look at a score based on step one, but now they've changed the exam to be pass and fail. Most competitive residencies previously were using the score itself to rate on the ability, I guess, academic ability of the student. So if you change that to pass fail, maybe you won't be able to distinct them as much as you can, I guess. But you know, step one was a very tough exam, and Yale gave us 2 months to study. And even with that amount of preparation, I can speak for myself and all my colleagues, we still went in with a lot of trepidation and
Right, yeah.
knowing how that one score would possibly determine our entire specialty. So in a sense, I think changing it to pass and fail will alleviate a lot of the stress associated with that exam. But I think it will be challenging for a lot of the residencies to make a distinction among the students, because a lot of medical students, even from the top schools, even regular schools, have excellent recommendations, and the entire package is fantastic. So I think that'll be a question for the program directors as to how they're going to tease out the top students or the good students from the rest.
Dr. Dolgen, you're on mute. I know you're trying to say something.
Dr. Dole, Steve, you're on mute.
Okay, the USMLE, United States Medical Licensing Exam, has 3 parts. Part 1 is short answer test based on the first 2 years of so-called basic science. It's quantitative and causes a great deal of competition, nail biting, and it has hurt people's careers if they score poorly. And this is a great advance. Medicine didactics now much more are we oriented toward how well people can synthesize, not so much into regurgitating facts. And it'll take a lot of pressure off of students, and it might make it a little different kind of a challenge for people who oversee residencies, but they'll be much better off if they pick people of a certain kind of substance than based on how well they take standardized tests.
So we've reached the end of our hour, but also, guess what? We've run through all the questions. I'd like to end, first of all, by just promoting the next Yale Career Panel, which will be on April 8th, which is on an intriguing topic, which is a candid view of post-PhD non-academic careers. So it's going to cover people who get a PhD and either decide they start teaching and then they change their mind, or they're in the middle of a PhD and they realize they don't want to be a professor, so forth. So that will be April 8th at 4:30, and we have a very, very interesting set of panelists. The last thing I want to say is I really, really want to thank the 3 panelists. I hope all of you who are watching agree that we had a lovely diversity of very talented doctors at different phases in their careers, and I think we accomplished our goal, I think, which is to give people at least a flavor of the kinds of things that you need to know in order to make a good personal decision about a career in the medicine. So I want to thank all of you, and I also want to remind everyone that all of these Yale Career Panels are recorded, and they can be found along with the schedule of previous events and future events at yalecareerpanels.com. So if you want to binge watch this and watch this panel repeatedly while you're stuck in shelter at home, you'll be able to do it in about 2 days. So thank you all. Thank you, Dr. Astro. Thank you, Dr. Lee. And thank you, Dr. Dolgen. Thank you so much. And I want to thank the audience and for the good questions they asked as well.
Thank you, Peter.
Thank you,
Very
Peter.
nice. I hope we get to meet in person one day.
Yes,
All right.
yes. Look.